and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app. Greetings from National Academy of Medical Sciences, India. Focusing on NAMS Vision 2030, NAMS is pleased to share some of the important activities like NAMS National, International Fellowship and Membership, Member After Day and Beam NAMS, NAMS Task Forces, AIMS NAMS Navigate, Navigate Medico CME, CME activities, publication of annals, newsletter, networking with professionals, public orations, Young Scientist Fellowship, Scientist Exchange Program, scientific visit of Emeritus Professor and many more activities. All application forms for fellowship, membership, associate fellowship, and member after day NB have been made online and objective criteria from the year 2022. NAMS has also started a new online NAMS Navigate CME and Navigate Medico CME program to assist in the development of competencies among PG students and share multimedia learning resource materials as e-library. NAMS has also started 21 task forces to address medical issues of national importance. Under publication activities, NAMS has its own annal as Annal of the National Academy of Medical Sciences. In addition, NAMS also publishes its quarterly NAMS newsletter. For more details of NAMS activities, please visit our NAMS website www.nams-india.in or scan QR codes with the camera app.
Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and allied health professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in basic sciences and applied clinical disciplines. In the virtual meeting held on 13 December 2022, more than 200 directors, deans, principals, CEOs, faculty members of the medical colleges and medical institutes decided unanimously that there is need for the NAMS National Virtual Graduated Medical CME, Navigate Medico CME program for PG students, MD, MS, DNB, MDS. Accordingly, the Navigate Medico CME program was launched on 22 January 2023 by the NAMS President, Professor Dr. S.K. Sareen. Each online session is of 2 hours covering practical aspects as per the needs of the PG students in the identified theme areas. Thank you for your kind support.
Hello and good afternoon, everyone. Welcome to the next session of NAMS AIMS Online Navigate Medico CME program. Today we have a very interesting topic that is approach to dyspepsia and H. pylori. So continuing with that, I would like to welcome Professor Umesh Kapil, Secretary, National Academy of Medical Sciences, for the welcome address, please.
Namaskar.
Hello, namaste.
It's really nice to see Usha ji after a long time
Yeah.
the AB2 ward as a DM student and now the
Hmm.
big boss of PGI Chandigarh. It's really, we are proud of you and your achievements and contribution.
Thank you, sir. It's been always wonderful associating with AIMS as well as NAMS, and these are leading institutions in the country. So I'm blessed to have been a part of several great institutions in the country as well as abroad. So it's really a learning experience.
Thank you very much. On behalf of National Academy of Medical Sciences, it's a proud privilege to welcome Dr. Usha Datta, an eminent gastroenterologist who is presently the head of gastroenterology at PGI Chandigarh. It's one of the most loved institution in northern part of the country. I've been there. My wife did her MD from that place, 86 to 88. It's something a wonderful institution, and the prime importance from them. And I think so. PGI is the one institution which have least number of holidays in the country because their patient care is the one which is highest priority for the PGI faculty, residents, and the training is outstanding. Well, we are most grateful to Dr. Govind Makharia, who has helped us, Professor Gastroenterology at All India Institute of Medical Sciences. We requested Dr. Makharia to have a series of lectures which can be undertaken in the field of gastroenterology, common areas in which people would like to know and update their knowledge. I give you a small background of the program. What is happening in the country that we have about 100,000 MBBS students who are coming out and they appear for the NEET examination or the out of 100,000, we find that as high as about 6,000 or 7,000 students get into the postgraduate program, and about similar number gets into the DNB program. So we have a pool of about 80,000 students who are interested in doing post-graduation, but they are unable to get it. Similarly, we have postgraduates who are trying to update their knowledge, and particularly, I must say, we do not have many good teaching program for the postgraduates. So, National Academy of Medical Sciences initiated this NAMS Navigate program. It is National Virtual Graduate Training Program. What we do is that we invite eminent faculty members who come and undertake a series of lectures of common interest, which to update their knowledge and skill, and subsequently what we expect them that they would be able to become a competent doctor in their own field. Apart from this, we also have all the presentations, PowerPoint on the NAMS website. So what happens that if a person is interested in listening to these lectures, they may go to the website, which we call it as a virtual library, in which they can download the PowerPoint, they can understand the presentations, and so it's for time immemorial we are going to have this virtual library. We also have a live telecast. As I can see, there are about 279 participants had joined on YouTube. So it's a very popular program, but as all things start gradually, we are moving towards success and we are going to enroll more and more postgraduates for this program. With these few words, again, I thank Dr. Govind Makharia, Dr. Usha Dattaji for helping us to undertake the Navigate program in a great success. With these words, thank you very much. Most grateful to you. Over
Thank you,
to
sir.
you, Dr. Yaswant, who is going to be a faculty member at All India Institute of Medical Sciences and Department of Psychiatry. Over to you, Dr. Yaswant.
Thank you, sir. With this now, I would like to welcome the chief coordinator for today's session, Professor Govind K. Makharia. Professor Govind K. Makharia is the professor in the Department of Gastroenterology and Human Nutrition at AIIMS, New Delhi. He is a governing council member and chairman of Clinical Research Committee of World Gastroenterology organization, which is the highest and most recognized professional organization in gastroenterology, and also as the council member of Asian Pacific Association of Gastroenterology. He is presently the president-elect of Indian Society of Gastroenterology. As the Secretary General of Indian Society of Gastroenterology, he initiated and nurtured many educational activities. Dr. Makharia is a member of Academic Committee of ICMR, DBT, JNU, and other eminent institutions. He has received many awards. He has trained around 102 fellows in gastroenterology and 9 PhD students. He has published 335 articles in the index journals, 43 chapters for different books, and edited a handbook on celiac disease. The H index of publications of his publications is 55, and his publications has been cited by more than 13,000 times. He has been listed among top 2% research scientists. The main area of his interest is celiac disease. So with this, I again welcome Professor Govind Makharia, sir, for his address,
Go by,
please.
Doctor.
Thank you. Sir, you are on mute, sir.
Thank you so very much, Dr. Sareen, Dr. Kapil, and whole team at National Academy of Medical Sciences. I think this is a wonderful idea. Taking these online series of lectures on different topics for postgraduates is one of the most wonderful things to do. And I truly appreciate this activity of National Academy of Medical Sciences. Now, coming to the series of lectures on gastroenterology, I think all of us know that about 1/3 or even more of our population have some form of gastrointestinal disorders, including dyspepsia, reflux disease, or functional GI disorders, hepatitis B virus, C virus, and many others. So therefore, we thought that talking about these common subjects will be very fruitful and very relevant for most postgraduates. And therefore, we designed a series of 6 lectures on gastroenterology. And all 6 will be very important in practice and also for exam perspective. In this series, we have the first talk. That's one of the most common disorder in gastroenterology, that is dyspepsia. 1/3 of our population is likely to have a dyspepsia. So what it is, how it happens, how to make a diagnosis, how to approach such a patient, and how to treat them. This one aspect. And also we know that 2/3 of our population are infected by Helicobacter pylori. So what to do with them, how to make a diagnosis, and how to treat them, and who to treat is what we thought is very relevant once we talk of dyspepsia. And for that, we have none other than Dr. Usha Datta. Dr. Usha Datta is a very dear colleague, I would say dear friend, and she's a professor and head of gastroenterology at PGI Chandigarh. She's very eminent in terms of a great teacher. I would say is a great educator, not only teacher, but an educator. I say educator because she's also influences many of her colleagues all around the country, not only the country, but also around the globe. So, and her contribution has been remarkable as a gastroenterologist, clinician, as a teacher, and also a researcher. She has done wonderful work in carcinoma gallbladder. Without wasting more time, I again hand over to Dr. Kapil and his team to invite Dr. Datta to deliver this lecture.
Thank you, sir. Thank you very much. So next I would like to now invite a speaker for today's session, Professor Usha Datta. She is the professor and head of the Department of Gastroenterology at PGIMR Chandigarh. She has a special research interest in gallbladder cancer, gallstones, IBD, micronutrients, gut barrier. She has numerous honors, awards, and recognitions in her name. She is ISC Professor Rakesh. She was awarded ISC Professor Rakesh Tandon Award for Best Mentor in 2021-22. CM Habibullah Oration of Best Researcher Award by ISG for 2020. Om Prakash Memorial Award for Outstanding Contribution as a Young Gastroenterologist. Young Clinician Award 1998 by WCOG Vienna in September 1998. Young Clinicians Award 2001 by Asia Pacific Association of Gastroenterology, Australia in September 1. Young Clinician Award 2000 by Asia Pacific Congress of Gastroenterology, Hong Kong in March 2000. The New Zealand High Commissioner's Prize 1988 for being the best undergraduate in the community medicine at AIIMS, New Delhi. She has H index of 35, I10 index 99, and publications more than 400, citations around 5,000. She has more than 40 awards. She has mentored more than 50 and has wrote 12 chapters. Ma'am is like very eminent personality in the field of gastroenterology. So with this, now I welcome Professor Usha Datta, ma'am. Please, ma'am, over to you.
Thank you so much for your kind introduction, and thank you, Dr. Govind and Dr. Kapil, for inviting me for this session. And as Dr. Govind has already highlighted, dyspepsia is the commonest symptom with which patients are coming to the outpatient clinic in any gastro setup as well as medical OPD setup. So that is why Dr. Govind decided to choose this topic. And in dyspepsia, H. pylori is the dominant cause of causing dyspepsia apart from functional dyspepsia. And that is why this is the only most treatable, easily treatable condition, and should also be treated in order to prevent CA stomach. Taiwan, China, Japan have various programs to look for H. pylori and eradicate H. pylori. So we would get guidelines from those countries and make our own guidelines so that for our country, we should be testing and treating H. pylori whenever we find it. So with this, what I thought is, since it is a session for postgraduates, we will discuss on what is dyspepsia, how to approach dyspepsia, and how to detect H. pylori and how to treat H. pylori. So this lecture is focused on some very basic key aspects which any postgraduate should know. So dyspepsia is a Greek word for bad digestion. The symptoms are localized to the epigastrium. Symptom is any upper GI symptom lasting for more than 4 weeks in the form of upper abdominal pain, discomfort, nausea, vomiting, or heartburn. The community prevalence of dyspepsia is about 30% in our country, but only 5% seek care. Those who are stressed out, those who are health conscious, and those who are worried about any history of possible cancer are the ones who seek consultations. It affects quality of life. It is associated with increased cost in therapy. It is associated with high healthcare burden, but fortunately does not increase mortality. So it should be diagnosed and treated in order to improve quality of life and decrease the healthcare burden. The symptoms of dyspepsia can be in the form of epigastric pain, epigastric burning, postprandial fullness, or early satiety. There's a difference between postprandial fullness and early satiety. In postprandial fullness, after the meal, the patient feels bloated and full. Whereas early satiety is as he is eating the meal with little amount, his stomach feels full. So there is a difference here, because in early satiety, there's difficulty in distension of the stomach. And in postprandial fullness, there's a possible problem with the motility of the stomach, resulting in a postprandial fullness. And epigastric pain and burning are both due to an inflammation in the stomach, which is initiated by acid and pepsin, apart from other causes. So epigastric pain syndrome is usually meal induced and is associated more often in an empty stomach. It can be meal induced or after empty stomach, but the postprandial distress syndrome, as the term says, is meal induced postprandial symptoms. So they can have associated bloating, belching, nausea, and very, very rarely vomiting. So if a patient of dyspepsia has a lot of vomiting, please look for gastroparesis, because unless you look for them, you will not find it. So then they need some gastric emptying studies to assess for gastroparesis. Otherwise, repeated vomiting should alert you to a distal obstruction or some other condition which is causing this vomiting. So just occasional vomiting may be a part of dyspepsia, and significant vomiting should alert you to a distal obstruction, biliary pathology, pancreatic pathology, and some other functional pathologies. So if we look at all patients with uninvestigated dyspepsia, we take a history, examination, and investigation, and we divide them into two categories: organic, that means you have found a cause, or functional, where you haven't found an obvious cause. Functional constitutes 70% of this, and functional disorders used to be called non-ulcer dyspepsia, but now they are called disorders of brain-gut interaction, because there is a lot of important role of gut and brain in causation of GI diseases. Among the organic causes, it can be a GI cause or a non-GI cause. Among the organic dyspepsias, if you look at the GI causes, the dominant one is H. pylori. Peptic ulcer disease, GI cancers can cause luminal GI disorders. And among the pancreaticobiliary, it is pancreatitis, pancreatic cancer, gallstones, and sphincter of Oddi dysfunction. So our main aim here is to look for H. pylori, to look for peptic ulcer disease so that we can prevent complications, to look for GI cancer so that we can detect it early and prevent its progression, and pancreatitis and pancreatic cancer, especially to detect early and give goal-directed therapies here. And if there are gallstones, to subject these patients to cholecystectomy, and in a rare situation to look for sphincter of Oddi dysfunction. So when you're sitting in the outpatient, how do you see whether the patient is towards the luminal side or the pancreatic or biliary side? More the pain is in the right upper abdomen, more if it is associated with nausea or vomiting, more if it is associated with increased severity, abnormal liver function test, or an ultrasound abnormality, consider a pancreaticobiliary disease. Among the non-GI causes, diabetes, hypothyroidism, organ failures, pregnancy, and several drugs and medications can all present with dyspepsia. Diabetes is very common, and hypothyroidism, in about 30% of them will have dyspepsia, 70% of those with organ failure will have dyspepsia, and 80% of those with pregnancy will have dyspepsia, and various drugs also cause dyspepsia. But here we have to see that there is lot of these patients should not get just empirical PPI, because this is a part of the disease manifestation. Unless it's extremely troublesome, we should not give proton pump inhibitors empirically in this group. In fact, the Indian Society of Gastroenterology is releasing a guideline on role of PPI in and use and misuse of PPI. Funny. Functional dyspepsia by Rome 4 criteria, we find that dyspepsia can be having 4 cardinal symptoms, as we highlighted: postprandial fullness, early satiety, epigastric pain, and epigastric burning. And these symptoms should be bothersome for the patient. Duration should be minimum of 3 months and an onset 6 months back. Because if the dyspepsia is going on for more than 6 months and the patient hasn't had other manifestations coming on, it is more likely that there is a functional dyspepsia in these patients. Other diseases with organic diseases would have deteriorated over a period of time and manifested with other features of the disease. And the postprandial distress syndrome should be present at least 3 days in a week, and the epigastric pain syndrome at least once a week. There should be no evidence of structural disease on endoscopy, and that is why in diagnosis of functional dyspepsia, there is a role of endoscopy in picking up any disease in the patient. And since it is not possible for us to do endoscopy in all the patients, there are several criteria by which we choose who is a patient who's likely to benefit with endoscopy. The types of functional dyspepsias are postprandial distress syndrome and epigastric pain syndrome, and there's a significant overlap in 35% of patients, and in a small percentage of them, 1/3 of them could have associated GERD, 14% could have associated IBS-like symptoms. In a study from India by Ghoshal et al. And Shah et al., this was rural-based, this was urban-based. What we found was 20% of our rural population is having dyspepsia, 30% of the urban population is having dyspepsia, and 64% have combination of postprandial distress syndrome and epigastric pain syndrome. And here in the urban situation also, 33% are having postprandial distress syndrome, 17% have epigastric pain syndrome, and 50% have an overlap. What is the epidemiology of dyspepsia? We find that 30%, as I said, are having dyspepsia in our country, similar to what is there in North America, similar to more or less in Europe, and similar about 24% in Japan and Australia. The interesting thing is between the prevalence and the nature and manifestations of dyspepsia in India versus West and East, we find 80 to 90% of our patients have evidence of H. pylori in India. This is similar to what we see in the West. In the East, that is more than 50%. In the West, the prevalence is lesser. So if you just follow Western guidelines, we may be misled in the wrong way. And in India, we still have a high incidence of CA stomach, and we are seeing more and more of early gastric cancer when we are looking around for it. And what is alarming is that CA stomach in India is affecting younger people who are aged less than 40 years. And you see, this is very small in the West. So in India, anybody who's more than 40 years, please start looking for any symptoms and signs of H. pylori infection or early gastric cancer so that we can catch it early. The 5-year survival in CA stomach is very, very low. That is just 6%. That means we are detecting them very early. That means we should start looking for it at a younger age, that is 40 years. A study from Chennai has shown that 18% of the upper GI cancers, the patients are less than 45, also because of associated high risk factors in the form of smoking, gutka, and tobacco chewing. All these things increase risk of gastric cancer also. So 43 years is a good age to start screening for men and 38 for women. So I think, practically speaking, if we say 40 years plus in India, we should start looking for early gastric cancer. Among various causes of dyspepsia, the pathophysiology, H. pylori is the most dominant. Apart from that, H. pylori itself can result in dysmotility, or dysmotility can be independent, acid, pepsin, duodenal microinflammation, psychiatric issues, and hypersensitivity are all hand in hand in causation of dyspepsia. And what we can easily do is work on the H. pylori, work on the diet, and give reassurance to the patient. So these things help in management of dyspepsia also. There has been recent paradigm shift in our understanding of dyspepsia, that it's not just the stomach, the duodenum is also involved. It's not just the motility, it is the mucosa which is driving the inflammation. From no bugs to the role of H. pylori and other microbiota, CNS to the enteric nervous system, playing a major role in the regulation of various pathways, and a symptom-based treatment to a target-based treatment like picking up H. pylori and treating that, and an algorithm-based treatment which is personalized. So there's something in the chat box. Yeah. So just one second. Yeah. So what determines the severity of the symptoms? Quite often in most diseases, the severity of the symptom depends on the amount of tissue injury. So if you have tissue injuries in the form of GI microbes, antibiotics, NSAIDs, this can result in further in the disease severity. And the perception of the patient, whether the stress, childhood abuse, depression, anxiety, all these can go hand in hand in causing the amount of symptom severity. So please assess these two components. Sometimes patients will be very, very anxious, but they don't have so much of injury, and there is vice versa. So how to evaluate these patients? Look for the symptomatology, systemic illnesses, drugs which the patients are taking, what is the diet they are taking. Increasingly, I'm finding a lot of junk food, outside food, poor quality oil, and not well preserved food. All are coming up into our Indian diet. Our diet is getting westernized, the gluten intake is increasing, and preserved food and ultra processed food is increasing. So this has a key role in causing dyspepsia. So please look for this, and also the timing of the diet and the amount of the diet and the lack of any routine fastings which used to happen in our Indian civilization. So all these things we are dumping the gut with stuff which the gut doesn't like. So obviously it will react and say that you are not eating right in the form of symptoms of dyspepsia. And also in India, we have high incidence of GI infections. Apart from H. pylori, any gastroenteritis can cause post-infectious dyspepsia, especially if it was a bout of severe gastroenteritis. So there's problems with food hygiene, which can affect our incidence of infection, and partially treated with antibiotic and not completely eradicated. So we have chronic low-grade infection of the gut, which can also change the microbiota and cause dyspepsia, and stress can modulate all of these things. So we specifically look for any alarm features, severity of the disease, and the nature of dyspepsia so that we can tailor therapy according to that. So what are the alarm symptoms? This is something all postgraduates should know. In the Western parlance, more than 60 years, a patient coming with new onset dyspepsia. In India, we should start seeing 40 plus. We should keep our eyes and ears open. But in general, we screen after 50 years as per the existing guidelines. Presence of evidence of GI bleed in the form of hematemesis, melena, or anemia, or stool or blood positivity, progressive dysphagia or odynophagia, persistent vomiting, as I said earlier, unintentional weight loss, family history of gastric or esophageal cancer, palpable lump or lymph nodes on imaging abnormality, NSAIDs or aspirin. So this is a very important slide for all postgraduates to question your patients whether they fall into any of these categories, and if they have, then these patients should be subjected to an endoscopy. On examination, look at whether they are obese or malnourished. Pallor, icterus, cervical lymph nodes would suggest the presence of CA stomach or lymphoma. Acanthosis nigricans is a feature of CA stomach, as well as metabolic syndrome. Presence of abdominal lump or tenderness. Presence of hepatosplenomegaly, ascites, signs of systemic illnesses. So we do a good general physical examination to pick up any subtle signs of any systemic disease. So in the hemogram, what will we find? We may find anemia, raised DSR to suggest a malignancy, peptic ulcer disease, or inflammation. We may find elevated renal functions to suggest underlying kidney disease, abnormal liver function test to suggest a pancreaticobiliary disease, raised TSH to suggest hypothyroidism, and a blood sugar which is elevated to suggest diabetes, and a stool examination to suggest presence of pathogens as well as GI bleed, and an ultrasound to look for gallstones, CBD stones, and pancreas to look for a pancreaticobiliary cause. So it is just this basic investigation which is required in these patients. So in uninvestigated dyspepsia, what do we do? According to the American College Guidelines, 60 years, Korean 40, Japanese 40, Maastricht 5, Rome 4, all these classifications have guidelines have suggested we do a history examination and investigation, and we look for any signs of non-GI dyspepsia like hypothyroidism, diabetes, and all those things. Otherwise, if the patient has alarm symptoms and age more than 40 years, if the alarm symptoms are present and the person is more than 40 years, please do an endoscopy, biopsy, and a rapid urease test. And if the rapid urease test is positive, then it is organic dyspepsia. If the upper GI endoscopy shows some disease pathology, it's an organic dyspepsia, and then we have to treat it goal direct. However, if the patient doesn't have alarm symptoms and the age is less than 40 years, these patients need not have an upper GI endoscopy. They can have a urea breath test or a stool antigen test for H. pylori. And if it is present, we treat them as H. pylori associated dyspepsia. If both of these are absent, haven't picked up H. pylori, haven't picked up any organic disease, then we label it as functional dyspepsia. So the diagnosis of functional dyspepsia is after excluding organic causes as well as H. pylori before we label it as functional dyspepsia. In dyspepsia, it is really not necessary to rule out celiac disease. However, certain guidelines may include such a thing, but usually in our patients, we do not look for celiac disease. Who needs endoscopy? Those with alarm symptoms with an age cutoff, as I said, of 40 preferably in our country. Upper GI endoscopy in India, there are some caveats. As I said, gastric cancer occurs at a younger age. It's an opportunity to pick up early gastric cancer only if you do a careful endoscopy. You can easily miss this. These are small depressed lesions here and there, so you have to see it. And in India, there's a peculiar situation. We have a patient visiting you from 300 kilometers away only once. So it is very important that 5, 10, 15 minutes that you give your patient, give a wholehearted time to them so that their coming that far is meaningful for them. And they're not going to come back again and again. Also, there is easy access to endoscopy. The cost of endoscopy is not prohibitive. And now with Ayushman Bharat also covering it for the poorer sections of our population, and even for out-of-pocket expense, it is not a very huge expenditure. So wherever it is indicated, upper GI endoscopy is useful. However, if you have had a patient who has had already an upper GI endoscopy in the last 2 years, there is no need to repeat it unless the symptoms have drastically changed or you're suspecting something sinister. So what do you look for in endoscopy? So here you can see in the esophagus, you can see evidence of esophagitis. You can see evidence of a hiatus hernia. This is a retroflex view of the G junction. You can see a hiatus hernia. You may find atrophy in the fundus with evidence of gastritis. You may find several polyps in the stomach body. You may find that there are multiple erosions on endoscopy. You may find that there are larger erosions with hyperemia around it. You may find that there's nodularity in the stomach. So when you see nodular gastritis, one of the dominant causes is still H. pylori apart from lymphoid hyperplasias, or you may find chronic atrophic gastritis, which is the feature of H. pylori gastritis. You may find an ulcer in the stomach. So wherever if you find an ulcer in the stomach, please biopsy them. Please repeat endoscopy so that you do not miss an early gastric cancer which has presented like this, and you should be able to organize successful resection of such a disease before it advances any further. So all patients with gastric ulcer need a repeat endoscopy at 4 weeks or 8 weeks to see whether there's a complete healing of the ulcer and it wasn't a malignant ulcer which was masquerading as just a gastric ulcer. You may find duodenal ulcers. Duodenal ulcers do not usually turn into malignancies. However, you should ensure that it is healed because it can get complicated. You may find linitis plastica. So linitis plastica is when you put the endoscope in and you try to distend and the stomach doesn't distend. These are patients who present with early satiety, and you can see these thickened folds which are not opening up on endoscopy. And here the first endoscopic biopsy may be missing an early or missing the diagnosis of CA stomach, because quite often these are infiltrating lesions and you have to do pars Alcian blue to look for the signet cells in these patients. On retroflexion, you can see a tumor here, advanced gastric cancer. You don't like to pick it up at this stage because they may have already metastasis. You would like to pick it up when there are early gastric cancer, small depressed areas where we have to look for dysplasia and malignancy. There's a role of narrow band imaging in picking up H. pylori by looking at the pit pattern, and they can also pick up early gastric cancer by looking at the fine network of vessels that we are seeing here. You may find gastroparesis, that means a lot of food residue in the stomach. You may find a pyloric stricture of an old duodenal ulcer now turned into a pyloric stricture there. You may find duodenal erosions, you may find duodenal nodularity, and you may find evidence of celiac disease in the form of grooving and scalloping and decreased fold height. So this, if you find, you should test them for TTG. Here you can see duodenal ulceration, the large ulcer which had come to us in a state of bleeding. And the important thing for us to realize is you send a patient for endoscopy and the endoscopy comes normal. So the patient is distressed, why did you get an endoscopy done? But we have to tell them about 70% of the endoscopies will be normal, which is good and reassuring. And there are other diseases which are more sinister are not there. So the patient should feel happy rather than feeling sad that his endoscopy is normal. When you do an endoscopy, it's very important by Sydney Convention to take biopsies from the antrum and from the incisura as well as in the body. These are done so that we can pick up H. pylori, we can pick up pangastritis versus antral gastritis, and we can pick up early metaplasia, which starts at the incisura. So minimum of 5 biopsies and fundic biopsy if the patient is on PPI or has CA stomach. This will help us in picking up any evidence of H. pylori sitting on in the stomach. Rapid urease test is a very important addition to every endoscopy suite where we should use validated kits. All of us should remember that RUT is positive when there are more than 10 to the power 5 bacteria. So in a patient who's on PPI, who has recently received antibiotic, the amount of bacteria in the stomach may be less than 10 to the power 5, and hence your RUT may be false negative. So a negative RUT does not exclude H. pylori because we have found that patients with negative RUT actually are H. pylori positive on PCR tests. So we have to be very careful to say that negative RUT is H. pylori negative. So stop PPI, antibiotics and bismuth minimum 2 weeks prior to the endoscopy. You can continue H2RAs like ranitidine, famotidine. If the patient is very symptomatic, the patient can be on antacids. You report the RUT at 30 minutes and 24 hours. So you see a negative one is yellow and the positive one is pink. Declare negative only at 24 hours. And also it is very important to understand that RUT is a chemical enzymatic reaction. So if the temperature of the room is very cold, you may have false negative RUT. So you'll have false negative RUT when you have less H. pylori, it's a cold room, there's evidence of intestinal metaplasia, GI bleed and gastric cancer. So these are areas where you expect H. pylori, but you may not find. So you have to be careful that these are not the false negative components. On biopsy, we may find a lot of gastritis, lymphocytic, plasmacytic, as well as occasionally neutrophilic, and you may find small crypts which are getting inflamed there with a lot of neutrophils there, and these are called pit abscesses, and if they are present, look carefully for H. pylori. You will find H. pylori sitting in the lumen as little gram-negative rods. So what is the relationship of H. pylori and dyspepsia in India? In India, most studies have shown 50 to 60% of patients with dyspepsia are RUT or histology positive for H. pylori. So H. pylori is a dominant problem. 60% are positive on stool antigen testing. Seroprevalence is about 10% higher. And this is because once you have H. pylori, you will be seroprevalence will always be there, but active infection is detected by presence of RUT positivity, histology positivity, or stool antigen positivity. H. pylori positivity is associated with more severe symptoms of dyspepsia, and the treatment results in reduction of symptom scores and resolution of symptoms. And H. pylori associated dyspepsia is useful for us to know, because if you eradicate H. pylori, the number needed to treat is 14. And this tells us that though only 1 out of 14 patients will completely resolve with symptoms, but as I said, it is important to also eradicate H. pylori to reduce the incidence of H. pylori related gastric cancer. So what are the caveats? Whom to test, how to test, whom to treat, how to treat, how to test for eradication. Whom to test? Anybody with antral gastritis, gastric atrophy, gastric ulcer, adenocarcinoma, moltoma should be tested. And there should be grade A evidence for that. Whom to test? Those with iron deficiency, ITP, family history of gastric cancer, NSAIDs, or those who are on long-term anticoagulants or NSAIDs, we should test for H. pylori. All patients with dyspepsia should be tested for H. pylori before we label it as functional dyspepsia, before starting empirical PPI for those with dyspepsia. Increased risk of gastric cancer if H. pylori is present, because if you just give PPI in patients with H. pylori, you are increasing the risk of gastric cancer. So you're doing harm by just giving empirical PPI. So empirical PPI is not the answer. The number needed to treat is 14. Sorry about the slide getting a little eclipsed. So whom to test and how to test? Age more than 50 or 40. You can use an invasive test like upper GI endoscopy, rapid urease test with histology. And age is less than 50 and there are no alarm symptoms. You use a non-invasive method like breath test, stool antigen, and serology. Testing caveats, as I said, no antibiotics for 4 weeks, no PPI for 2 weeks. Test if it's positive, treat. Beware of false negatives. And as I said, RUT is positive only if it is more than 10 to the power 5 bacteria per gram of tissue. Serology is not affected by PPI or antibiotics. So if you think that the patient has high chance of having H. pylori and your tests are coming negative, in that subset, you can use serology to help you. And treatment needs to be individualized because it may mean a past infection. So then came the big debate in our country that when 50-60% of our patients are H. pylori positive and the number needed to treat is 40, should we be testing and treating them and adding so much of cost and time to such a thing? But if we evaluate the risk benefit, we find that though the risk is in terms of cost, logistics, resistance, reinfection, and recrudescence, but the benefit outweighs the risk. It decreases the symptoms, decreases the cancer incidence, decreases ulcer incidence, decreases bleeding, and decreases iron deficiency. So overall benefit outweighs the risk, and that's the way to go. In a mass eradication of H. pylori done at the Matsu Island, it was found that after H. pylori was eradicated, the prevalence of H. pylori steadily went down, and more interestingly, there was a 53% reduction in gastric cancer from 2004 to 2016. And this was reported by Chiang et al. Whom to treat? All symptomatic patients with H. pylori should be treated. All patients before starting long-term PPI, NSAIDs, or anticoagulant should be treated. All those with asymptomatic H. pylori infection should be treated, and those with family history of gastric cancer to be treated. Essentially, if you see it, treat it, remove it, and test for eradication. How to treat, which drugs, what dose, what duration, and how to tailor for a patient. We have 8 drugs which are cornerstones. 8 drugs. First is PPI because it suppresses the H. pylori. Metronidazole because it causes free radical damage to DNA of the bacteria. Clarithromycin inhibits protein synthesis, amoxicillin inhibits the cell wall synthesis, quinolone inhibits the DNA synthesis, rifabutin inhibits DNA polymerase, and bismuth inhibits the enzymes and the additions, and probiotics inhibits the addition. So note that all of these are antibiotics acting through different mechanisms of action, and combination has a better yield because a single drug hardly ever eradicates H. pylori. So it has to be a combination therapy for an appropriate duration before we can expect eradication. As I said, amoxicillin is a cornerstone. The dose is 1 gram twice a day, and more than 3,000 milligrams, that is more than 3 grams, has higher efficacy. So amoxicillin has an important role, not only in directly acting against the bacteria, but also to decrease the chance of clarithromycin resistance. So when we look at clarithromycin, it inhibits the protein synthesis of H. pylori, and the dose is 500 BD. Quinolones again inhibits the DNA synthesis, and levoflox and moxifloxacin has been used in H. pylori treatment. Metronidazole has an important role. However, in India, it has very high resistance, so we don't use metronidazole in eradication of H. pylori in India. Rifabutin is a second-line agent which we use whenever we are having problems with eradicating with the first-line regime, and it is used in a dose of 150 milligram PD. Bismuth is a very useful drug. It's a low-cost drug. It doesn't have resistance, and it is effective as an add-on therapy in all these regimes. So I routinely use bismuth so that our patients benefit with this simple agent, which is low cost and yet doesn't have resistance pattern. And it's a cornerstone therapy for high resistance area. Bismuth is available in 2 formulations, colloidal bismuth and bismuth subsilate. So colloidal bismuth is what is easily available, and we have to give 120 milligram 4 times a day. Clinicians hesitate just because they don't know about the drug. It's available if you ask for it, and patients have some black stool, but we know that it is not melena. But the advantage is it's a low cost, low profit. Now it is available in India because we have kept on advocating for all the pharma companies to bring it in. And also it has very low resistance. Probiotics, there's an emerging role as an add-on therapy to the regime in order to decrease biofilms as well as act on the various microbiota alongside the H. pylori. So, but the exact role needs to be further defined. So which regime and what duration? So the cornerstone is PPI. PPI, best quality PPI, should be given to all patients who are undergoing eradication therapy. Amoxicillin is the second important drug. So PPI and amoxicillin are there, the cornerstone. What are the drugs we have to play with them? Metronidazole in India, there is no role because of resistance. We have clarithromycin, which is a very useful drug in these patients, but there is an alarming increase in clarithromycin resistance in our country, levofloxacin and tetracycline. So these are the 4 drugs we have. We also have to add bismuth to that because bismuth has an important role in eradication. So our regimes usually contain a PPI, amoxicillin, one of the 4 agents here, and bismuth. So which regime? So one is a standard triple therapy. So let us see of all these regimes. One is standard triple therapy. So here we are having proton pump inhibitor, amoxicillin, clarithromycin, or you can have metronidazole instead of clarithromycin. As I said, in India, metronidazole is has very high resistance, 60 to 70%, so we don't use it. So in the first week, you give these 3 drugs. In the second week, also you give the same 3 drugs. So this is called the standard triple therapy. What is sequential therapy? Sequential therapy is in the first week you give 2 drugs, and in the second week you give 3 drugs. And the first 2 weeks, when we give PPI and amoxicillin, it makes the H. pylori more sensitive to use of clarithromycin in the next week. So this is again a very popular regime in certain places, but we don't use it very often. So what I actually use is concomitant therapy. Concomitant therapy means using 4 drugs at the same time for a period of minimum 2 weeks. So this is what I practice, where we use PPI, amoxicillin, clarithromycin, and as I said, we should not be using metronidazole, so I use bismuth in this situation. The hybrid therapy is 2 drugs in the starting and then 4 drugs at the end. So here you see, just like sequential, here also it's starting with 2 drugs, but it will have a role in the second week. It is 4 agents, which is called hybrid therapy. The bismuth quadruple therapy has basically PPI, metronidazole, tetracycline, or bismuth. You can substitute the metronidazole by amoxicillin and tetracycline by clarithromycin. So bismuth quadruple therapy basically has PPI and bismuth and 2 other antibiotics. So that's what in a nutshell is bismuth quadruple therapy. So the regime, as I said, which we use most often is concomitant therapy, and with 85% efficacy. And here I usually substitute the metronidazole for bismuth. So we should use that regime, which has more than 90% eradication rate. It should be preferably concomitant therapy or hybrid therapy. These are superior to the triple therapy, which is the standard therapy. 14-day treatment is better than 10 days, which is better than 7 days therapy. Which one is better? So if we see, the base drug is PAC, that is PPI, amoxicillin, clarithromycin. And if we compare to this base, PPI and amoxicillin is 1.43 times more efficacious. And bismuth quadruple therapy is again 1.47 times more efficacious. Sequential therapy is 1.72 times more efficacious. And we have the non-bismuth quadruple therapy, which is 2 times more efficacious. There's emerging role of vonoprazan, amoxicillin, and clarithromycin therapy, which is 3.8 times more efficacious than the standard triple therapy. However, vonoprazan is not yet there in India, but it has very strong proton pump inhibitor action and has great efficacy in the management of H. pylori. So what do the guidelines say? The guidelines says in India that we use this combination of 3 drugs with where there's low clarithromycin resistance, or we use a combination of 4 drugs with bismuth where there's high clarithromycin resistance, and where there's dual resistance. That means dual resistance to amoxicillin, to clarithromycin as well as levofloxacin. Preferably use PABC, that is PPI, amoxicillin, clarithromycin, and bismuth. So which PPI? Higher the dose, higher the efficacy. Newer generation PPI has higher efficacy. So minimum I use 40 milligram twice a day of PPI to bring in the most efficacy. And newer generation PPI has higher efficacy like rabeprazole, esomeprazole, and vonoprazan. And PPI has shown that if you have vonoprazan, the eradication rate is as high as 90%, which is very, very small for the routine omeprazole-based therapies. Vonoprazan is a new agent. It has rapid, profound, and sustained acid suppression, and it's useful in the eradication of H. pylori. So what are the ways by which we can increase the efficacy? That is 14-day therapy, new generation PPI, high dose amoxicillin, bismuth addition of possible probiotics. All of these increase the efficacy of the regime. And things which decrease the efficacy are antibiotic resistance, smoking, poor compliance, obesity, CYP, C2, C19, polymorphisms. All of these will reduce our efficacy. So very important to ask the patient to stop smoking, to reduce their weight, and ensure good compliance. So how do we increase efficacy of whichever regime you choose? You can add a bismuth to increase the efficacy by 10%, add a probiotic to increase the efficacy by 13%, or add a probiotic to a bismuth regime to again increase the efficacy by 11%. And here, wherever you have clarithromycin, it can be replaced by levoflox if you have resistance to clarithromycin. So that will increase the efficacy by another 10%. And you can substitute the PPI to vonoprazan to improve the efficacy by another 13%. So what is the algorithm we follow? If we have low clarithromycin resistance, we give 3 drugs for 14 days. What do? We give 3 drugs for 14 days, and that is clarithromycin-based triple therapy, that is PPI, amoxicillin, and clarithromycin. PPI, amoxicillin, clarithromycin. Clarithromycin has 500 BD, PPI has 40 BD, and amoxicillin has 1 gram BD for a total duration of 14 days. If this regime fails, you can shift to bismuth-based quadruple, that is PPI, amoxicillin, clarithromycin, and bismuth. And if this fails, the other option we have is levofloxacin quadruple therapy, which has PPI, amoxicillin, levofloxacin, and bismuth. If this fails, you give this, and if this fails, you give this. And if both of them fail, then you give rifabutin-induced triple therapy in these patients. If you're living in a high clarithromycin resistance area, or you do not know about the clarithromycin resistance, or there's a recent history of macrolide use, like somebody using azithromycin or clarithromycin, then what option do we have? You first can try bismuth quadruple, that's what I do. And if that doesn't work, then we can go to rifabutin-based therapy, that is called the PARB, where we have rifabutin as well as other agents in this management. And here we have, if there is high fluoroquinolone resistance, we prefer rifabutin. And if you are not seeing a lot of fluoroquinolones, you can consider levoflox-based quadruple triple therapy. So how do you test for eradication? Very, very important that all patients who are treated should be tested for eradication. You give treatment for 2 weeks, give PPI for another 2 weeks, no medications for 4 weeks, and then you test. You can test by urea breath test, you can test by H. pylori antigen, and you can test by upper GI endoscopy if there is a gastric ulcer. So what are the key points in H. pylori management? Look for it. Treat it if you find it. Use only standard combinations. Ensure compliance. Very, very important. Ensure compliance. Spend a few minutes with your patient and ensure that he will take it. Only 14-day treatment duration is acceptable. No more 7 days and 10 days therapy. And check for eradication always. So as I said, the non-invasive strategy is stool antigen and urea breath test. They have a specificity about 95 to 97%, but it also has a problem that the sensitivity is only 88% for the stool antigen. So we may miss 12%, and we should keep the patient off PPI and antibiotics prior to the stool antigen testing, urea breath testing, as well as RUT. You do endoscopy only if there are those warning signs or we are suspecting something sinister, then we go ahead and do endoscopy. And a negative RUT does not exclude H. pylori as highlighted above. So the overall benefits, as I said, for eradicating H. pylori in the management of dyspepsia, the benefit outweighs the risk. And how to eradicate, we already discussed that though we eradicate, the number needed to treat is only 14. This is only one study which has been quoted again and again. And there could be resistance developing. So when you first hit hard and hit well, so that all the H. pylori which is sitting there goes away. PPI has a cornerstone in the management and it suppresses H. pylori. H. pylori gets into a replicative state and the acid reflux pumps are inhibited. There's emerging multi-drug resistance due to biofilms, and this is becoming a very big problem in our country. And clarithromycin resistance is increasing. Recently, we did a study with LAMP PCR and found that out of the samples that we tested, about 194 samples, which were predominantly from 2 centers, that is PGI as well as from Calcutta, and we found 17.8% resistance. So we are looking at the antibiotic emergence pattern all over the country, and there is possibility that our data will show high resistance areas. So in Asia Pacific region, there's a rising incidence of resistance to antibiotic. Resistance pattern has been looked for in several other studies, and we do find that this is a very concerning thing. The resistance pattern, as I said, in India, 70% are resistant to metronidazole, 17% to clarithromycin, 6% to levofloxacin, amoxicillin in about 18%, and tetracycline in 11%. So can we test it bedside? We tested it bedside using LAMP PCR, and the LAMP PCR suggested presence or absence of H. pylori, as well as it suggested whether the patient had clarithromycin resistance or not. So here just the tissue which is taken during endoscopy is put into a small ependoff, homogenized, boiled, centrifuged, and the supernatant is taken, and we use that in a specific regime with a LAMP reaction, and looking at the color, we can say that it is positive or negative. So here in India, we found that in 198 patients, 67 were LAMP PCR positive. And here we did find point mutations to suggest clarithromycin resistance. So what is the Indian perspective of dyspepsia and H. pylori? Add bismuth, choose a high dose PPI, choose new generation PPI, choose higher doses of amoxicillin, ensure compliance, give a 14-day therapy only, replace clarithromycin with levoflox and rifabutin, and do not use metronidazole and tetracycline for other indications. So we already discussed how to follow up these patients and what are the other steps in management. So any patient with dyspepsia, this is an overview. Do a prompt endoscopy if they are more than 50, or they are having alarm symptoms, or they are having evidence of significant weight loss, or they're very anxious about it. Test and treat patients if our empirical therapy. So these are our 3 regimes we have. So what we do is patients who are more than 40 who have alarm symptoms, they go for endoscopy. Those who are less than 40, no alarm features, cost-effective strategies, test and treat compared to empirical treatment. And then we differentiate whether it's epigastric pain syndrome or postprandial distress syndrome. Epigastric pain syndrome, we give PPI for 4 to 8 weeks. For postprandial distress syndrome, we give PPI with or without prokinetics for 8 weeks. If there is no response, as I said, there's a role of stress and other mediators. So psychotherapy, tricyclic antidepressants, combination therapy, and complementary therapy are useful in managing this vexing disorder. Diet is a very, very important trigger for dyspepsia. Small, frequent meals, increase fluids, fiber, and fruits. So the 3 Fs, and decrease the 3 Os, that is oil, overeating, and odd meal times. Decrease the 3 S's, that is smoking, spices, and caffeine, and avoid NSAIDs. We have to bring in some lifestyle changes with a good sleep and a lot of physical activity in the form of walking and cycling. So a simplified approach: dyspepsia, alarm symptom, endoscopy. Dyspepsia, no alarm symptom, high H. pylori prevalence areas, test and treat strategy, and confirm that you were eradicated. If there are no alarm symptoms, no H. pylori, but the patient has epigastric pain syndrome, treated with PPI. If it is postprandial distress syndrome, you can use PPI or with or without prokinetic agents. So diet, lifestyle, and reassurance are important, so that once you withdraw the drug, the diet, lifestyle, and reassurance will be the cornerstone. If there is no response, then you do psychotherapy and tricyclic antidepressants. So here we come to the last slide, take-home messages. Dyspepsia is a common and vexing problem. 70% is due to functional dyspepsia. We look for associated GERD and IBS. Carefully rule out organic causes. Individualize the approach for each patient. Do a prompt endoscopy if there are alarm symptoms. Look for H. pylori when you're doing endoscopy. Look for early gastric cancer so that we don't miss it. Test and treat if the alarm is negative. If the patient is H. pylori positive, treat it. If there is epigastric pain syndrome, give PPI for 4 to 8 weeks. Postprandial distress syndrome, give PPI and prokinetics for 8 weeks. Avoid empirical or long-term PPI therapy. Diet, lifestyle, and reassurance are cornerstone in therapy. Thank you.
Thank you very much, ma'am, for explaining the very important topic to very simple and we can say which can be understood by the person who is not like specializing into medicine or gastroenterology. So thank you very much for covering this wonderful topic, ma'am. Ma'am, there are two questions which are passed on YouTube. The first question is, ma'am, thank you for this important topic. Kindly guide about the complications associated with the long-term use of PPI and H2 blockers.
Yeah, so very important question. I had to take off these slides because of, otherwise the lecture would be just too long. So PPI is a big problem in our country because it is over the counter available. Second is in the West, it is only available on prescription with the number of the registered medical practitioners. So there is rampant misuse of PPI in our country. And once the patient starts PPI, they will go on PPI, and then that becomes long-term use. And long-term use is a problem because three things happen. One is the PPI itself can have some drug reaction, can cause interstitial disease of the kidney or some, but this is the least important in terms of its prevalence. The second most important thing is acid is required for our digestion. The nature takes so much of effort to make the acid through the proton pump inhibitor system, the proton pump. And we inhibit it with just one tablet, and then there's no acid. No acid means no digestion. No digestion means there's going to be bacterial overgrowth in the distal part of the gut. So no digestion also means that the patient is not going to get nutrition. So there's B12 deficiency, iron deficiency, which are all features of chronic PPI use. The third problem is chronic PPI use causes a change in the gut flora and thereby increases incidence of these multiple polyps in the stomach, which is very commonly seen. Most of these polyps are innocuous, and in general, PPI doesn't result in CS stomach. But if there's H. pylori and you have just given PPI, it will increase the incidence of H. pylori induced CS stomach because now the flora is changing and there's no check and balances of acid in the system. Yes. Shall we go to the next question?
Yeah. Thank you, ma'am. Next question asked is, as you mentioned, functional dyspepsia constitute around 70% of the total. So the treatment of choice. So what is the treatment of choice for the functional dyspepsia? Also, if there is any link between dyspepsia and migraine.
Yeah, it's a very important thing. 70% have functional dyspepsia. So that is why if you saw the last slide, I reiterated that if functional dyspepsia has epigastric pain syndrome, that is epigastric burning or epigastric pain, then these patients require proton pump inhibitors in a BD dose for minimum of 8 weeks. If the patient has postprandial distress syndrome, that is early satiety or postprandial fullness, bloating, belching, these are the patients who again need PPI. And in this subset of patients, we may benefit by adding a prokinetic also in order to take care of the symptoms. Now, what is the link between dyspepsia and migraine? Now, I find that patients who don't digest their food well, don't have healthy eating habits, more likely to have some absorptive disorders and some deficiencies. And these patients, quite often, these conditions like dyspepsia and GRD, dyspepsia and IBS, dyspepsia and migraine, these all coexist because the starting point of all diseases is in the gut. So what you feed it, when you feed it, how you feed it, if you're doing it the wrong way, you're going to cause dyspepsia, and you're also going to cause other disorders in the body like migraine. I find calcium deficiency and is very common in those with migraine. And then when we supplement calcium, improve the digestion and the nutrition, we can have some link between them. But I'm not aware of direct one-to-one studies. I can share that with you on email once I can look at them.
Thank you, ma'am. There were two questions only as of so now, continuing with the session, I would like to welcome Professor A.K. Sood, sir, for the vote of thanks. Sir, please.
Thank you so much, Dr. Jaswant. On behalf of the National Academy of Medical Sciences, it is my great pleasure to thank the eminent speaker for this evening, Professor Usha Datta, ma'am. Thank you so much, madam, for covering this very common topic in a very simple way. I'm sure that the practical tips which you have given will be useful for our students. And we look forward for your support to the Academy in future also. Thank you very much.
Sure.
We will also like to place on record the support which we have got from the Chief Coordinator for this series on gastroenterology, Professor Govind Mukharia, sir. And he has selected the best speaker and the best topics. So thank you so much, sir, for your support to the Academy. I will also like to thank the participants who have attended this particular question and made this session more interactive. I'm sure that the practical tips which has been given will be useful to you for your day-to-day management as well as for your exams. And for the information of the participant, especially the PG student, I would like to mention that please note that the timing for this Navigate CME program has been shifted to Fridays. So now on every Friday, we have this Navigate Medico CME program. Just to tell you that this gastroenterology series is going to cover on third Friday of every month. For example, the next session in gastroenterology is on 20th of October, which again is the third Friday. And there we are going to cover another very interesting topic, bowel syndrome, by a very eminent speaker in that. So please tell your friends to attend this session. And if you want to attend more sessions, for example, on first Friday of every month, we have in collaboration with AIMS, all the AIMS in the country, they have kindly agreed to work with them. And we are taking common topics which are common across all the specialties. For example, on 6th of October, from 3 to 5, which happens to be again the first Friday of the month, we are going to cover hospital-acquired infection, and another topic is on patient safety protocols. So like that, on first Friday of every month from 3 to 5, in collaboration with AIMS, where the AIMS PG student as well as other medical college PG student can join. So please join these sessions also, will be very useful. There we are going to cover common topics across all the specialties, like soft skills for the management of patient, for example. Then we have how to provide good consultation, and hospital ethics, but medical ethics, like that we have identified the topic, experts have identified the topic. So please attend that. In addition to that, on fourth Friday of every month, we're going to have another very interesting series of lecture in collaboration with the Association of Physicians of India. So that association has kindly agreed. In this series, we are going to have senior physicians from all over the country, 2 to 3 physicians. They will share their experience, how they did it, and that will be very encouraging for you, especially for your career, for your clinical practice. So please remember to attend that. And on second Friday of every month, we are going to have orthopedics. This we are going to start from next month. So please remember, Friday, 3 to 5 is going to be a very interesting session for you, where you will get the opportunity to interact with the best speaker. I will also like to thank my colleague here, Dr. Jaswant, for creating the session. He has been associated with NAMS for this program from the very beginning. Thank you so much for taking time and coming to us. So we are grateful to you. I will also like to thank our IT team here. We have Mr. Ravi and also Mr. Anil, who have been helping us in writing letters to you before the session, and also Zoom link as well as the ensuring that this is telecast on the YouTube. So with these words, I will like to thank once again all of you who have been with us this evening and made this session very interesting. Thank you very much. Over to you, sir.
Thank you. Thank you very much, sir, for the kind words. And I'm privileged to be the part of the National Academy of Medical Sciences. Again, thanking you, ma'am, and thanking you, sir, Professor Govind Makharia and Professor Usha Datta, ma'am. Sir, thank you. And with this, I think with your permission, sir, we can mark the closure of this session. So thank you and good evening.